Assalamu alaikum. This presentation is on how the stomach contents can backflow into the pharynx and the larynx and the effects of such a reflux. The backflow of the stomach contents into the esophagus, the gastroesophageal reflux, occurs in most people. It is so common that it is considered a normal physiological phenomena, so long as it occurs within certain limits. It occurs mostly after meals and in bed in the supine position. It has short episodes of reflux, does not normally cause any symptoms, and does not cause damage to the esophageal mucosa. So long as the esophageal mucosa is not exposed to the acid in the reflux for more than 5% of the 24 hours period, and that the reflux remains inside the esophagus, not beyond, then it can be considered a normal physiological gastroesophageal reflux. The esophagus has certain properties and mechanisms that can physically remove and chemically neutralize the refluxed bolus. When the gastroesophageal reflux starts to cause symptoms to the patient or signs of inflammation or erosion in the esophagus, then it is termed gastroesophageal reflux disease. The tissue damage is thought to be acid-mediated due to the exposure of the esophageal mucosa to the acid in the reflux material. It's still so common to the extent that 20% of the adult population, normal adult population, has reflux symptoms for at least once a week. Half of these number, 10% of the adult population, can experience these symptoms on daily basis. And 10% of patients in the outpatient, in the ENT outpatient clinic has one form or the other of several diseases related to such a reflux. When the reflux reaches the larynx and the pharynx, and it's termed Laryngopharyngeal Reflux, it can be demonstrated in up to between 10 and 30% of asymptomatic normal adults. And about more than 50% of the patients who presents with hoarseness can have reflux into the pharynx, and about 40% of patients who present with chronic cough in the outpatient clinic can also have reflux in the larynx or the pharynx. What is the pathogenesis of the gastroesophageal reflux disease? It's usually a combination of different factors. A defective lower esophageal sphincter is the primary factor, plus one or more of the contributory factors. A defective lower esophageal sphincter can be either due to impairment of the resting tonic contraction of the lower esophageal sphincter, the tonic contraction that keeps the sphincter closed except when it receives a peristaltic wave with a bolus from the esophagus. If this resting lower esophageal sphincter is impaired, then this can give a form of severe gastroesophageal reflux disease, and this can be prolonged exposure of acid to the esophageal mucosa. But it can happen like transient impairment in the lower esophageal sphincter, only brief episodes of reflux. This transient but inappropriate relaxation of the lower esophageal sphincter can happen in the absence of peristalsis and are referred to as transient lower esophageal sphincter relaxation. This transient lower esophageal sphincter relaxation can last for anything between 10 and 60 seconds and can allow the escape of some of the stomach contents into the esophagus. It can also have a relaxation of the not only the sphincter but also the crura of the diaphragm that supports the tonic contraction of the sphincter. The transient relaxation is mediated by a vagal reflex, and it is one of the primary causes for gastroesophageal reflux, and it is the primary cause in normal individuals. The contributory factors are numerous, including things like obesity that increases the intra-abdominal pressure and also affects the integrity of the sphincter, hiatus hernia that affects the integrity of the sphincter, diabetes mellitus that type 2, and diabetes would cause gastroparesis with accumulation of food in the stomach and increase of the gastric pressure and increase the chances of a reflux. It can be due to a connective tissue disorder that can either affect the motility of the esophagus or the integrity of the valve, or reduce the secretions of the esophagus that protects it from acid exposure. Things like scleroderma, rheumatic disorder, Jogren syndrome, several mixed connective tissue type, including the Zika syndrome. And of course, diet containing things like chocolate, caffeine or alcohol, peppermint, and spicy food can all increase the acid content of the stomach and can also reduce the lower esophageal sphincter tonicity. And some medications, including non-steroidal anti-inflammatory drugs, opioids, and anticholinergics. When reflux goes anywhere beyond the upper esophageal sphincter, it's termed extra-oesophageal reflux. That is reflux beyond the upper esophageal sphincter. And it can affect areas like the oral cavity, the paranasal sinuses, the middle ear, and of course the pharynx and the larynx. When it affects the pharynx and the larynx, it's termed laryngopharyngeal reflux. This is one form of extra-oesophageal reflux. The laryngopharyngeal reflux events can happen in the upright position rather than the supine position in the classic gastroesophageal reflux disease. And although gastroesophageal reflux disease and the laryngopharyngeal reflux may exist independently, as the disease severity increases, the likelihood of the two being present together also increases. A panel of experts from the International Federation of Otolaryngological Societies, the IFOS, had agreed on a consensus on the definition of laryngopharyngeal reflux and how to diagnose it and manage it. On the definition, their consensus was that laryngopharyngeal reflux is a disease of the upper air digestive tract resulting from the direct and or indirect effects of the gastroduodenal contents refluxing into the pharynx and the larynx. They also agreed that it induces morphological and or neurological changes in the upper aerodigestive tract, and that the laryngopharyngeal reflux and gastroesophageal reflux disease share some common pathophysiological mechanisms, but may present with different clinical pictures. And of course, laryngopharyngeal reflux has, in addition to the defective lower esophageal sphincter, also has some defect in the upper esophageal sphincter, allowing retrograde flow of the bolus above the upper esophageal sphincter into the laryngopharynx. When laryngopharyngeal reflux occurs, the pH of the pharynx decreases dramatically. The mucosa of the larynx and the pharynx, unlike the esophageal mucosa, are not well protected against the effects of the reflux. They are not rinsed with saliva normally, so small amounts of the reflux are capable of inducing injury to the respiratory epithelium in the larynx, for example. The laryngeal mucosa is either delicate squamous epithelium over the vocal folds or a respiratory type of epithelium in the subglottis and the supraglottis, both of which are far less resilient than the esophageal mucosa in resisting the effects of the reflux. The refluxate is neither removed by peristalsis nor neutralized by bicarbonate like in the esophageal secretions. Tissue damage in laryngopharyngeal reflux is induced by activated pepsin, sometimes by intracellular inactivated pepsin as well, in contrast to the damage in gastroesophageal reflux, which is acid-induced. Also, the damage in the larynx and the pharynx can happen very rapidly following exposure to the acid, and episodes as brief as 30 seconds, repeated 3 times per week, can induce damage in the larynx, as opposed to the esophagus, which can withstand reflux, physiological gastroesophageal reflux, so that as long as it does not exceed 5% of the duration of a 24 hours duration. In addition to pepsin, the refluxate also contains other components, including hydrochloric acid, which is important in lowering the pH to levels necessary to activate the pepsin. This is how the proton pump inhibitors work, by inhibiting the production of hydrochloric acid and preventing the activation of the pepsin. It may also have pancreatic proteases, especially trypsin, particularly in patients who had gastrectomies or gastroenterostomies, or patients who are taking proton pump inhibitors. The refluxate can also have bile acids, mainly in the conjugated form. The free bile acids can cause tissue damage. And there are also partially digested food residue, bacteria, and notably the Heliobacter pylori can have some clinical relevance. The reflux material, the refluxate, can take the liquid form or take the aerosol form. The aerosol form has been detected deep in the bronchi or in the middle ear, and also in the exhaled breath of patients who have laryngopharyngeal reflux. In the liquid form, the acid content would have a higher concentration, both of the acid and the pepsin, but in the aerosol form, the refluxate could go further and injure other parts further away from the larynx and the pharynx, like deep in the bronchi or in the middle ears, for example. Normally, the esophageal mucosa is protected from the effects of the reflux material by certain defensive systems. First, the tone of the lower esophageal sphincter, which remains in tonic contraction most of the time and relaxes only during swallowing and occasionally during belching and vomiting. If reflux material finds its way to the esophagus, there are mechanisms for reflux bolus clearance. First, the gravity and the esophageal peristalsis. And after clearance of this bolus, there are systems to neutralize the acid left over the esophageal mucosa. There are acid clearance mechanisms, including the bicarbonate contents of the salivary and esophageal gland secretions. And thirdly is the epithelial resistance. The mucosa of the esophagus contains a mucus layer and an aqueous layer with high bicarbonate level to neutralize the acid. If a reflux finds its way beyond the upper esophageal sphincter, there are other defensive mechanisms that would help to protect the pharynx and the larynx from the effects of the bolus. These reflexive mechanisms, activated by the distension of the esophagus or pressure stimulation directly on the pharyngeal wall. And they result in certain reflexes, including stimulation reflexes to stimulate the upper esophageal sphincter tonic contraction. These include reflexes from the esophagus, distension, upper esophageal sphincter reflex, and from the pharynx, pharyngoesophageal sphincter reflex, and from the larynx, the laryngoesophageal reflex as well. The other system is a closure of the glottis if there is stimulation of the glottis by the esophageal glottal and the pharyngoglottal closure reflexes. There are also other response mechanisms in place, including stimulation of the pharyngeal swallow and a secondary peristalsis to clear out any residual reflux material in the pharynx, and also distension of the esophagus by the refluxate that results in pharyngeal and esophageal volume clearance. These further mechanisms and systems reduce the chance of the refluxate contact with the trachea, the larynx, and the bronchial mucosa. The main defensive mechanism against laryngopharyngeal reflux is the upper esophageal sphincter tonic contraction at rest. This sphincter formed out mainly of the cricopharyngeus muscle, with contribution from the lower fibers of the thyropharyngeus muscle and the upper circular fibers of the esophagus. This upper esophageal sphincter maintains at rest a tonic contraction with a pressure reaching 90 millimeters mercury plus or minus 30 millimeters. This tonic contraction pressure at rest may be increased sometimes It can be increased if the larynx is stimulated by the reflux, a microaspiration of the reflux, or by acid in the distal esophagus, or by a drop in the tone of the lower esophageal sphincter. These three factors can increase the tonic contraction from 90 millimeters to more than 240 millimeters mercury. On the other hand, the tonic contraction may decrease sometimes. It can decrease during belching. Here there will be a complete transient relaxation of the upper esophageal sphincter to allow the passage of the gases from the stomach and the esophagus. Also, there may be low residual upper esophageal sphincter pressure. A residual pressure in the upper esophageal sphincter may drop to 10 millimeters mercury, or between 10 and 25 millimeters, but only for a very brief period. So transient relaxation of the upper esophageal sphincter may occur, and this can allow some refluxate to pass from the esophagus to the pharynx. This also happens particularly in the supine position when there is some acidic residue in the esophagus and the individual swallowing would relax the upper esophageal sphincter and allows the passage of the residual acid refluxate in the esophagus backflow into the pharynx and the larynx. When these defensive mechanisms fails and the refluxate reaches the larynx and the pharynx, direct injury to the tissues may happen due to several factors. The main factor is the direct epithelial contact, the microaspiration of activated pepsin in the reflux material. Pepsin is activated by a low pH induced by the acid, the hydrochloric acid in the refluxate. The stomach secretes acid at a pH less than 2. A cutoff point of pH less than 4.2 would induce gastroesophageal reflux disease. The same threshold was also suggested for problems related to laryngopharyngeal reflux. A level of less than 4.2, although it has been shown that pepsin can be activated at higher pH values up to 6, 5, between 5 and 6, you can still get some activity in the pepsin. So the direct effect is the main cause of injury to the laryngeal and pharyngeal epithelium. This can be helped also by the direct effect of the acid itself and other components of the refluxate, including bile salts and some pancreatic enzymes and bacterial products in the refluxate. A comorbidity, coexisting other factors like, for example, trauma from vocal abuse or repetitive throat clearing or coughing, concomitantly with the injury induced by the pepsin, the activated pepsin, could also explain the development of the laryngopharyngeal reflux signs and symptoms. The other factor are neurologically mediated. These can be reflexes in the larynx or in the bronchi induced by the reflux in the laryngopharyngeal segment. Laryngospasm can happen. These are sudden adduction of the vocal folds when the reflux material reaches and starts to penetrate into the larynx. Also, the chemoreceptors in the larynx could, through a reflex arc mediated by the superior laryngeal nerve and back through the recurrent laryngeal nerve, cause the sudden adduction of the vocal folds and may also contribute in chronic cough. The other cause for chronic cough in reflux patients would be the acid in the distal part of the esophagus that stimulates another reflex, a vagally mediated reflex, directly from the distal esophagus to the bronchi. So basically, the pathophysiology of the laryngopharyngeal reflux is induced by activated pepsin from the pepsin and the hydrochloric acid in the refluxate, and the effect of the pepsin on the cells of the larynx and the pharynx have been demonstrated in laboratory studies and also in clinical observations of the vocal folds and other areas in the larynx and the pharynx. The mucosa would congest and would swell with edema, and the ciliary function would be affected, causing stasis of thick mucus that would give rise to sensation of a postnasal drip, and also would induce attempts at throat clearing, which would add further injury to the mucosa of the larynx. There may be a contribution of other components in the refluxate, including bile acids and pancreatic enzymes and bacteria in the refluxate, and the neurological impact of the refluxate. When the reflux reaches the larynx, it induces certain neurological reactions, including laryngospasm, for example, and associated with changes in the upper esophageal sphincter spasm and things like this. The main agent for the injury of the mucosa of the larynx and the pharynx in laryngopharyngeal reflux is pepsin. Activated pepsin by the lowering of the pH induced by the hydrochloric acid. Pepsin is at maximum activity at a very low pH level of 2. This is the pH at the stomach level, but even at a higher pH levels, pepsin may retain some activity up to a pH of 6.5, just below normal levels at 7.4. Pepsin has been demonstrated on the surface of laryngeal epithelium in laryngopharyngeal reflux patients, but not in healthy individuals. And the pepsin on the surface of the laryngeal epithelium would be endocytosed, would be engulfed inside the cells, and would remain there in small vesicles. Sometimes it can be reactivated when conditions are favorable, like a drop in the pH, in the intracellular pH, and this would lead to cell toxicity. This can happen even with a very short exposure to pepsin. Even with a very brief exposure to a refluxate containing pepsin, there would be a demonstrable epithelial cell injury of the larynx and the pharynx mucosa. Although gastroesophageal reflux disease and laryngopharyngeal reflux share some common pathological and clinical features, there are also some differences between the two conditions. In gastroesophageal reflux disease, the main problem is esophageal mucosal irritation, esophagitis, and erosion, and the main symptom is heartburn. This is rarely present in laryngopharyngeal reflux. In GORD, the main problems would happen at bedtime in the supine position, whereas in laryngopharyngeal reflux, the main symptoms would be during the day and in the upright position. There is usually some abnormal esophageal motility disorders in GORD associated with prolonged esophageal acid exposure. The acid exposure is very brief in laryngopharyngeal reflux, and it has intermittent episodes of the reflux. The main dysfunction in GORD is in the lower esophageal sphincter. The main problem in laryngopharyngeal reflux is a dysfunction of the upper esophageal sphincter. You can have some throat symptoms in GORD if the two conditions coexist together, but throat symptoms are the main symptoms in laryngopharyngeal reflux and are basically due to damage or injury to the laryngopharyngeal epithelium. Several methods of quantification of the severity of laryngopharyngeal reflux include the quantification of pharyngeal reflux episodes, number of episodes of pharyngeal reflux in 24 hours, or the percentage of time of acid exposure in the 24 hours time. For the first technique, the pharyngeal reflux episodes, some authors suggest that even one single episode of pharyngeal reflux is abnormal, whereas others suggest that pharyngeal reflux between 4 and 18 exposure episodes during 24 hours may still pass as normal. Anything up more than 18 is abnormal. Obviously, counting the number of reflux episodes may not be sufficient owing to the varying duration of the exposure, so other methods of quantification of the severity are in place. Other quantification methods for the severity of the LPR take into account things like the duration of the pharyngeal reflux episode. The average duration for a pharyngeal reflux episode in asymptomatic people with no symptoms would be very brief at about 6 seconds. The longest acid exposure in patients who have no symptoms, healthy controls, would be 19 seconds. So this is the duration for pharyngeal reflux episodes in asymptomatic individuals. Whereas in patients who have laryngopharyngeal reflux signs and established diagnosis, the average length of a pharyngeal reflux episode would be much higher at 30 seconds compared to 6 seconds in the asymptomatic individuals, and the exposure time may extend up to 16 minutes as compared to 19 seconds for the longest pharyngeal acid exposure in asymptomatic individuals. The acid exposure times in laryngopharyngeal reflux patients is the relative duration of the acid exposure, the total duration of acid exposure in relation to the 24 hours multiplied by 100. This is very low in normal controls or patients who don't have symptoms of laryngopharyngeal reflux. Although episodes of laryngopharyngeal reflux are quite common in healthy controls, up to 30% in some estimations, the acid exposure times is extremely low at less than 0.01% in some studies, and with a maximum of 0.01% in others. In other individuals who have a reflux of laryngopharyngeal reflux of a weak acidic episodes, pH around 5, the median acid exposure time is still very low at about 0.1%. That's 1 in 1,000 of the time they would have some exposure of the acid. The upper limit of normality was 1.5%. A significant proportion of the patient with LPR would have a weak acidic reflux into the pharynx. About a fourth of the patient with LPR would have a non-acidic reflux, and about a third of these patients would have either a mixed acidic and non-acidic reflux or a weak acidic reflux. This usually happens after meals, the occasion in which postprandial reflux happens due to the combined effect of transient lowering of the tonic pressure of the lower esophageal sphincter mediated by or triggered by gastric distension, and the non-uniform intragastric buffering effects of food in the early periods of digestion. Pepsin retains its activity to a pH between 5 and 6, so there may be still some pepsin activity with a weak acidic reflux. This weak acidic reflux may be furtherly neutralized by things like secretions of saliva and the esophageal glands mucus. Both of them can neutralize partially the acid in the refluxate, but the weak acidic reflux is usually seen more in patients who are already on proton pump inhibitors, which would normally decrease the amount of hydrochloric acid secreted by the stomach. And finally, there is a subset of patients who have silent reflux. These are patients who present with laryngopharyngeal reflux symptoms and sign in the absence of the classic gastroesophageal reflux disease. Rather, they would have physiological gastroesophageal reflux with no signs of inflammation or erosion in the esophagus and no gastroesophageal reflux disease symptoms. So this subset of patients would have only laryngopharyngeal reflux symptoms in the absence of any classic gastroesophageal reflux disease symptoms. These patients will be labeled as having a silent reflux. By this, we come to the end of this presentation on the mechanisms of laryngopharyngeal reflux. Assalamu alaikum.